All right, so we'll start now. Hello, my name is Jesse Rosenberg, and I will be moderating this seminar today. If you have any questions, please place them in the chat box on the bottom right so that they can be answered when it is time. After the workshop, please fill out the survey, which will be sent to your email to let us know what you thought of tonight's presentation. Tonight's presenter is Dr. Mark Komrad. Mark is a psychiatrist in a private practice and on the clinical and teaching staff of Johns Hopkins Hospital in Baltimore. He uses both psychopharmacology and psychotherapy, a combination treatment that has become increasingly rare in today's mental health care environment. Let's welcome Dr. Comrade to the seminar.
Hello, and hopefully people will be joining as we move along. But it's very nice to be back with you. Maddie just reminded me that this is my 9th year with the Harvest of Hope. Really wonderful. It seems remarkable that just seems like yesterday I first came to meet you all. It's unfortunate that we're not meeting in person, although there are certain advantages of this, but I really enjoy coming and spending the day at the Harvest of Hope conference, and always either give a talk or typically 2 sessions of Ask the Doctor. So I understand I'm the last event in this month-long harvest that has been going on. So I'm proud to be the caboose, if not the grand finale of this wonderful conference. And I was actually there at the opening keynote with Robin Williams' son, which was really quite fascinating. So I don't know, because I can't see a show of hands as I would in person, if everybody knows me here, because I come back each year, but there may be some new people that don't. And so let me, before we dive into some Q&A, and hopefully give a chance for people to type in some questions in the chat box or the Q&A box, either one. I'm monitoring both screens. So as you heard, I'm a psychiatrist, and I am, my primary work at this point in my career is in private practice. But I'm also on the academic faculties of Johns Hopkins, University of Maryland, and Tulane down in Louisiana. And in addition to treating patients, I have another dimension to my career, which is as a medical ethicist. And I do a great deal of consulting and teaching and speaking all over the world on issues in psychiatric ethics. One in particular that I've become very involved with lately, which we can talk about if people are interested. So I do that. Also, I have had a very long career in the media, and that means I've consulted on a number of Hollywood films, but I have appeared very regularly on TV and radio talking about topics in psychiatry. As a matter of fact, that's how I ended up sort of doing these kinds of Q&As, which I actually do for NAMI in many, many different states. And most years I do something similar in the national NAMI meetings. NAMI is actually a very important part of my practice, my secret weapon, if you will. It's not unusual for me to pull out my prescription pad and write, go to a NAMI workshop, or go to the family and family workshop, or go to a peer-to-peer support group. So NAMI is something that I use very, very robustly in my clinical work. The main thing, though, with regard to me in the media, is that throughout the late 90s and early 2000s, I had a radio show that went coast to coast across the United States. It was on the American Radio Network. It was a 2-hour live talk show, and had about 43 million listeners. And the typical format was, with one of those hours, I would interview a colleague about some special interest area in psychiatry, and we'd take calls. But in the other hour, I would do open phones. And as you might well imagine, the phones really lit up in the open phones hour. And in that time, I would invite people to ask me whatever they've always wanted to ask a psychiatrist, but never had the time. And to brainstorm with me on a variety of topics, from neurology and neuroscience to psychotherapy and psychology to thinking about mental health treatment systems and some of the challenges and vicissitudes of mental health in America today, to issues about insurance and prior authorization, you name it. But interestingly, I found that one of the most typical questions that people would call in and ask me would be something like, my wife, my child, my grandmother, my friend is clearly troubled in a way that's way more than I know what to do to help them. How do I convince them to have a consultation or to get some treatment with somebody like you, a psychiatrist or other mental health professional? So that was such a common question, and we brainstormed it so much, it really became sort of one of the major themes on the show. And as a result of that and my national profile with that, I started to develop a very special interest in that. And really for the next 20 years, people have come to consult me really from all over the world about a loved one. Most commonly, the typical example is an adult child who has clearly troubled with some kind of serious mental health disorder, to try to work with the family to see what's been tried, what's not been tried, to get that person into some kind of state-of-the-art professional treatment. So after 20 years of doing that, I sort of put everything that I learned over those 20 years about how to do that into this book called You Need Help, a step-by-step plan to convince a loved one to get counseling. And so yes, this it's a bit of an advertisement, but also to kind of give you a sense of where I'm coming from, that that resulted in this book. But really, it all started with open phones. And really, in a way, I consider this activity that we're doing tonight kind of like open phones, where you can throw at me any question that you have in these regards, and I will try to respond and answer, as I have for the last 8 years with you guys. And I do, throughout the country with other groups, other NAMIs, and so forth. So that being the case, we can open the phones, so to speak. At the moment, we really only have one question, and that is a question from Marie, who asks, can you tell me if Prozac causes weight gain? So I think that's a very interesting question, because I think it brings up something very interesting about medications and how things play out over the course of the years that they're released into the wild. When Prozac was first marketed, the original initial studies showed, in fact, that Prozac was not much more likely to gain weight than placebo. And so one of its original marketing features was that it doesn't cause weight gain. Now, what was very clear is it definitely caused a lot less weight gain than what had been available prior to Prozac. Because prior to Prozac, we really only had two major categories of medication. One was the so-called tricyclic antidepressants. Some of you who've been around a while might remember names like amitriptyline and nortriptyline, or Elavil and norpramin would be the brand names, desipramine, and MAO inhibitors like Parnate and Nardil. And those original antidepressants that were really the first out there in the 1960s and 70s did cause a lot of weight gain. So by comparison, Prozac did not cause nearly as much. And in those initial studies, it seemed to not cause much more than placebo. However, when a medication is studied, and all of the things that have to be submitted, the studies, the that have to be submitted to the FDA to get it approved typically involve a very selective group of people. There are a lot of people that are excluded from those kinds of studies, such as women, because they could get pregnant. And when you have a brand new medicine, you don't know what its effect on pregnancy and the fetus is going to be, so you exclude women. And you exclude people who have substance abuse. And you exclude people who have complex medical problems. And so there are all sorts of exclusions. So you have a fairly pure group that you are including in your study. So that's why when a medication is finally approved and released into the general marketplace, sometimes we see some very different things than were seen in the original studies that were used to get FDA approval. And Prozac is an excellent example of that, because once it was released into the wild and would start to be used by, a very broad spectrum of people, no restrictions, except insofar as any individual physician felt a restriction was necessary with the patient. It turned out Prozac did cause weight gain in many people. Not everybody, but in a lot of people. And my own personal experience is that when I think about medication, that if a patient is really concerned about that, there are now enough choices that I do not choose Prozac. Now, remember, when Prozac first came out, if a patient was concerned about weight gain, you definitely wanted to go with Prozac because it was way better than those old medications that I spoke about. But now, with the elaboration of maybe 30 medications since Prozac, that's no longer the case. There are a number of medications now that don't cause weight gain. And as a matter of fact, it's once we've broken through that barrier of being able to develop a medication that doesn't cause weight gain, you cannot economically win by trying to bring a new antidepressant to market that does cause weight gain, because there's no way it'll be able to compete with the meds that are out there that don't cause weight gain. So now failure to cause weight gain or being weight neutral is a must for any new antidepressant on the market. So not only do I hope that answers the question, but I think that it also shows my style. And my style, and you'll all forgive me, but hopefully you'll find it useful, is that I over-answer questions. And I over-answer them because I want to take the opportunity to teach you as much as I possibly can as a springboard for many individual questions. So in that sense, I hope that I can inform you about far more things than just merely limited to the questions that that are being asked. All right, so let's move on. And the next is from Jesse. Do you think mental disorders are presently well understood by science? What about psychiatric drugs? All right, well, I think that's a very interesting question. It's a very broad question. The glib thing would simply be to say no and move on. But I owe you more than just that. I think there's so much we do not understand about mental disorders. I think in many ways, psychiatry now is certainly made a lot of advances. Psychiatry now is in a state of development that's somewhat similar to the state of other fields like cardiology and so forth, where they were back in the 18th century. Maybe the early 19th century. We understand sort of what are the typical phenomena about what can go wrong in mental life. We have some ways of categorizing it. We have some ideas about certain things that are causative, both in terms of biological causes as well as psychosocial causes. But frankly, we do not have a highly developed correlation between those causes. So, I can tell you in tremendous cellular detail what the underlying cause of a heart attack is. And I can really spell out for you the whole sequence of events. We simply cannot do that with most mental illnesses. The other thing is that, you know, NAMI is the National Alliance on Mental Illness, right? So one of the things I like to do, especially when with an interactive audience, is asking people, what is their definition of mental illness? Is mental illness one of the major conditions like schizophrenia? Does it include minor conditions like attention deficit disorder or an adjustment disorder when you're having difficulty coping? Is mental illness only something that people who go to psychiatrists have? Is it only something that people who are on psychiatric, if you're on a psychiatric medication, that's a mental illness? Or if you've been hospitalized, is that the definition of a mental illness? If you're disabled, is that the definition of mental illness? Fact is, there is no universally agreed upon definition of what mental illness is. It frankly means, almost in political utilization, sort of whatever you want it to mean, because it's very heterogeneous. Frankly, the things that disturb the domains of thoughts, feelings, and behaviors, the three domains of mental life, are very wide and varied. And the way in which we think about mental disorders is very wide and varied. Some are best understood as diseases due to neurochemistry, broken brain, if you will, in various forms. Some disturbances have to do more with some abnormal life experiences, traumatic experiences, distorted learning paradigms, reinforced behaviors that have created dysfunctional behaviors thanks to those reinforcements. Some of these ways of people suffering in the domain of mental life have to do with the dimensional variability of human beings, right? I mean, some people are tall and some people are short. And if you are extremely tall and you're living in a world where houses are designed for people who are 5.5 feet tall, if you're 6 feet tall, you're going to be banging your head a lot and suffering a lot. Does the fact that you're 6 feet tall mean that you have an underlying biological abnormality? No. It's that you live in a society that has been designed for people in the middle of the bell curve, and you're at one end or the other of a tail. So people differ in their temperaments, they differ in their personalities, they differ in their vulnerabilities, and depending on the milieu that you're in, where those different sliders are on the sliding scale of human traits, you may find yourself suffering or getting into troubles, the likes of which we in mental health are prepared to deal with. And then there are some problems that have to do more with the meaningful things that have happened to you. You know, why does somebody have difficulty committing in relationships? Is that a mental illness, by the way? But certainly it's something that we deal with in mental health. Well, it may well be because they have had experiences of abandonment in their childhood by people that they trusted and loved and counted on to support them. So that's a way that things meaningfully emerge from one's life story. So we think about these sort of 4 different dimensions, which is disease, behaviors. So disease is what you have. Behaviors is what you've learned. Dimensions, which is more about sort of who you are and your traits, and life story, which is what you've experienced in your life. And those are not all mutually exclusive categories, of course, but all of that put together, that whole melange, is the total universe of mental illness. So to say, do we understand mental disorders? It's kind of like saying, well, how well do we understand physical disorders? disorders, right? Well, there's so many different physical disorders. Depends on which ones we're talking about, right? Some physical disorders are best understood as a broken part. Others due to nutrition or inadequate physical activity and so forth. So it's a bit of a trick question, if you will. Not that the questioner meant to trick me, but I think that the heterogeneity, the diversity of mental problems in mental life, or maybe a much more straightforward way of me saying it is the kinds of problems that come knocking on my door as a psychiatrist are many and varied. They do not have any one explanation. I'm going to leave that question there rather than now telling you a whole thing about the second half of the question, which is psychiatric drugs. We can probably circle back to that within another question. All right, moving along next is Janet, who asks, what treatment do you recommend as best for those who have social anxiety? Well, that's a very good question, and it's somewhat similar to my answer in the last one, and that is, social anxiety has a lot of various causes, right? Some of which we understand is biological, some of which has to do with people's life experiences on the basis of having trauma in the course of their lives. Some of it, excuse me, has to do with the way people use substances as a way of greasing social interactions, which ends up creating problems for them. So I think it's very individual. We have a variety of different approaches, and which is the most optimal really depends on the specific person. Some people really would benefit most from medications, such as serotonin reuptake inhibitors, the class of medications that includes Prozac and Zoloft and Celexa and Lexapro and Luvox, and some of the newer serotonin medications like Vibrid and Trintellix. Other people, and by the way, none of these are mutually exclusive, would very much benefit from group therapies in which they encounter other people who may have some similar problems, anxieties about social situation, to be able to create an opportunity to have an experiential corrective experience facilitated by a trained group leader and professional. They very much benefit from that. Some people may benefit from other kinds of treatments. There's a role for some people for hypnotherapy in social anxiety disorders, as there is for many anxiety disorders. There's a role for other kinds of exposure therapies, many online things that are now available, not just online support groups, but online experiences where you can begin to encounter other people from a little bit more of a safe distance, such as Zoom. For example, a lot of my social anxiety patients have welcomed the era of Zoom in the COVID pandemic as an opportunity to try to participate in things on Zoom that they find much easier, sort of a more introductory approach to interacting with others that feel a little safer to them and easier from behind their computer screen. So the bottom line answer is there is no one treatment that is best for any specific disorder. If you ask me that about schizophrenia, about bipolar disorder, about PTSD, about phobias, about OCD, I would have answered it the same way. There is no one best treatment, which, Frank, and by the way, I have nothing to apologize for on behalf of psychiatry. If you would ask the question, what's the best treatment for hypertension, right? We would be having the same discussion. Well, for some people, it's a dietary intervention. For some people, it's exercise. For some people, weight loss. For some people, medication. And these are not mutually exclusive. They can work together. And if you ask me what's the best medication for hypertension, I would say, well, there are like 25 of them, and they work in 15 different ways, and it depends. It depends on what side effects you want, what side effects you don't want, and what is the specifics of a specific patient. So psychiatry, like any other branch of medicine, there is no universal starting point for the treatment of any condition. There's a subset of interventions that are available for certain conditions, but where you start depends on many factors and the individuals. One of my favorite quotes is from one of the most famous physicians in American history, Sir William Osler, who was one of the founders of the institution that I'm affiliated with, Johns Hopkins. And he was one of the founding father doctors of Johns Hopkins. And he famously said, if people were more alike than they are different, then medicine would be more of a science and less of an art. Let me say that again. If people were more alike than they are different, then medicine would be more of a science than it is an art. And it's a complicated way of saying it. I frankly think it's a very eloquent way of saying it, but what it really means is that the variation among individuals is extremely important part of medical care. So that the one size cannot fit all. So which size do you choose for a certain person? Well, it's as much an art as it is a science. All right. Next on the list here is Madeline, who says, do you think that telehealth has the potential to bring care to more people? And that is an easy question. The answer is absolutely yes. No question about it. Now, and it's already happening, and we're already seeing that. One of the positives, I mean, there are lots and lots of negatives about the pandemic, but there are a lot of silver linings in the pandemic. And one of the silver linings, of course, is the opening of telehealth. And it's been there all along, kind of hiding in plain sight. But it's just something that was very difficult to do. It was highly regulated. You had to have in the past, the patient sitting in a special HIPAA protected location. Nobody could do it from home. You had to have special equipment and so forth to be set up to do it. And frankly, particularly we in psychiatry, who have long been used to experiencing both the information as well as the pleasures of sitting with people personally, rejected it, myself included. I've had FaceTime for years on my iPhone. And I have, in the past, had negative feelings about telehealth and doing video things. But then it was forced upon us, and we all got used to it. And now, frankly, I can't imagine why I was so against it in the first place. So it's helped, for example, a number of people who couldn't make appointments with me as much as they needed to because they couldn't get out of work to drive, from their workplace to my office in the middle of the day, because that's when I had an appointment available for them in the middle of the day, or they came from a long distance away and it was, a 2.5 hour experience by the time they drove and saw me and then went back. There were people that were also, many people with agoraphobia were afraid to leave their home. And there were a number of barriers to being able to see people. Most of those barriers have been taken down. The other thing is that in the midst of the pandemic, this is going away now, most states also opened their teleborders to allow physicians from any other state to treat their patients on telehealth without having to have a license in that state. Because, legally speaking, I'm really only allowed to treat people who are in Maryland. They have to be Maryland citizens, but there have to be boots on the ground in Maryland, Marylanders. But within the pandemic, I could start treating people also in all sorts of other places, including remote places that didn't have enough psychiatrists So that was a tremendous boon because of the emergency status, the emergency crisis. And I didn't have to get a license. And by the way, it's difficult to get a license. You have to have background checks. You have to spend, it's very expensive to apply for a medical license in a state. There's a lot of bureaucracy to it. You have to get recommendations. You have to, get copies of your diplomas and so forth. I mean, it's a real hassle to get a license to practice medicine, which is the license I know about. And it's not that much different for psychology and social work in a state. What a gift it was to me to be able to, and a lot of my patients, by the way, left. Many of the people went home to their families and COVID in another state. It was a tremendous opportunity for me as well as for others to not have those restrictions in the pandemic. P.S. This summer, most states closed that down. Most states decided the state of emergency is over. We are now closing our teleborders to healthcare, and that's really unfortunate. And there's now a lot of lobbying efforts to see if we can get that to remain open so that people can have more access to each other, and also to maybe even there's some push now to see if we can get a national medical license so that a doctor can practice telehealth in any state in the United States. So organizations like my professional organization, the American Psychiatric Association, in which I'm very involved and active, is one of those organizations that is lobbying Congress for this kind of thing. All right. I'm going to, the next question, I'm going to skip over anybody who's asked before. We'll come back for seconds, but let me get to firsts. Next is Jackie. What have been your observations about the effect of the pandemic on mental health? Oh boy, for that I need coffee. Well, so there's kind of two categories that I would answer that. And I'm going to rein myself in because I could go on the rest of the evening. In fact, if you look up on YouTube, look my name and NAMI and COVID, you'll see I did a whole workshop for NAMI Maryland on that issue. So you can dive into 90 minutes of my thoughts about this. But to encapsulate it and give you the cliff notes, there are kind of two categories, right? One is the effect that it's had on people who have already psychiatric disorders and are in treatment. And the other category is how it's brought on psychiatric problems in those who previously have either not had it or not been in treatment. So with regard to the first, I think that there have been, we've talked about the good things, right, like telehealth. But in terms of the negative aspects, I think there are many things that we can point to. I think it's been very difficult for people to get emergency crisis care. It's certainly early on in the pandemic, people were really reluctant to go to emergency rooms. Hospitals there's already a shortage of inpatient psychiatric beds to begin with. In the best of times, it's a whole other topic. But in the best of times, there was a shortage. Hospitals started to decrease their census in order to be able to not pair up patients in rooms. So places where they didn't have private rooms, they turned all the rooms into private rooms. You couldn't get into a psychiatric unit at first, especially if you were COVID positive. As a matter of fact, still, if you're COVID positive, some psychiatric hospitals will not accept you. In terms of what is become an even more widespread form of treatment than inpatient care, which is partial hospitalization or day hospital or intensive outpatient programs. First, all of those shut down for a while. They were completely closed for many, many months, maybe even some of them as long as a year. And then they started to get with the program and start to do Zoom. And I will tell you, for people who are ill enough to need that level of intensity of care, partial hospitalization, day hospital, and IOP. Zoom does not hack it. It does not hack it. I'm not even going to get into all the limitations of Zoom. After I spoke about the value of Zoom, it's got a lot of limitations, especially for very seriously ill people. So all of those programs became decimated by the pandemic. And even now, some of them are beginning to open again now, but a lot of them still remain largely done by telehealth. There were difficulty with people getting their medications, supply chain issues about medications. Anyhow, I can go on and on, but first, let me now switch to the other category, which is how the pandemic has affected people who are not pre-existing cases. We know that there's now an emerging mental health pandemic. It's not fair to call it a pandemic because pandemic implies that something's contagious, but certainly a mental health crisis for new cases, people who have had the devastating impacts of the epidemic. One, that's the most literal one, is people who've had COVID. And we know that 1 out of every 3 people who have had symptomatic COVID have had psychiatric consequences or neurological consequences, some of them quite serious. We've seen COVID-induced psychosis. We've seen lots of COVID-induced depression, particularly in those people who have so-called long COVID, which, by the way, is not a small minority. We've even seen some people who are relatively asymptomatic with regard to the usual symptoms of COVID develop anxiety and depressive disorders that we do believe is part of the biological consequences of the pandemic. So that's sort of the biological effect. But then there are the psychosocial ravages, right? The lost jobs, the way in which people have been crammed together, right? So having problems such as increased domestic violence, for example, with among people who are shoehorned together at home, not being able to get out to work. Anxiety for those who do have to get out to work and work in the front lines and expose themselves to the increased risk of having COVID because they can't afford to quit their jobs in those frontline positions in which they're much more likely to be exposed to COVID. We see a very significant increase in mental health problems among physicians. I'm one of the founders, and early on did a lot of work with something called the Physicians Support Line. We established a free online crisis support system staffed exclusively by psychiatrists for doctors during the pandemic. So we actually have 800 volunteer psychiatrists. It's wonderful. And we each take an hour on call, and we're available for doctors. You have to be a doctor to call, totally confidential, physician support line. If you know somebody who's a doctor, you can have them take a look at the website of the physician support line, but it's an 800 number. And I will tell you, I have dealt with lots and lots of suicidal doctors, substance abusing doctors, completely overwhelmed and burned out doctors. And now we're seeing a second wave. So there was the first wave of the physicians, when people were overwhelmed and dying and, morgues were filling up and bodies were stacking up in the conference rooms, like in New York City. It took a lot of calls from New York City in those days. Now we have the second wave. And the second wave, of course, is somewhat similar to New York City, but in much more rural areas like Idaho and Iowa and places like that. But also physicians who are suffering what we would call from moral injury. What's moral injury? Moral injury is feeling a sense of outrage that this isn't what I signed up for. Now, initially, that was not having enough protective equipment and stuff like that. But now the number one most significant mental health problems that I'm feeling among physicians is related to their sense of outrage at the stage of a pandemic that we in medicine considered completely preventable, almost completely preventable, thanks to vaccinations. And as you know, people on the front line in the trenches who are working in hospitals and intensive care units, the vast majority of people that they see are unvaccinated and did not have to be there. And even the few people that they see who are vaccinated, who've had breakthrough infections, got those breakthrough infections from a relative who wasn't vaccinated. So in the time of Delta. So doctors are quitting, nurses are quitting, and many of them are really suffering. And we've had a tremendous epidemic of suicides among healthcare professionals. So my goodness, if that can happen among healthcare professionals, what can we, expect for the general population? So increased anxiety, issues with kids and schooling, I could go on and on. So that's about as much right now as I want to take time for talking about this question about how the pandemic has affected mental health. All right, we're going to go from, let's see, we have a question from Janet, from Marie. I don't know whose question this is, but let's see.
It's from Marie, Dr.
Marie.
Komrad.
Okay, from Marie. I'm going to come back to that because Marie actually asked the first question. So I'm going to see if there's anybody else here. It looks like pretty much we're ready for seconds. Okay, so the question from Marie. Now, what happened to the question from Marie? Lost it here. Well, I'll get to it. Let me just kind of go back to the top here. All right. All right, question from Jesse. What, in your opinion, is the best way to help a loved one who's experienced a drug problem and keeps relapsing after leaving rehab? All right, well, of course, I've answered the question about what's the best way to help a loved one in 265 pages in the book. So that's my glib answer. If you really want to know my complete answer, you can read it in those 265 pages. I think that we know that relapse after drug rehab is actually very common. The median number of, for those people who've been to rehab, who have an illness severe enough to need rehab, the median number of rehab stays that a person with a substance use disorder has before they've reached sustained sobriety, defined as 5 years of sobriety, is between 2 and 3. Remember, the word median means half the people have had fewer and half the people have had more. So relapsing and going in and out of rehabilitation programs for substance abuse is pretty common, pretty typical, until you can get traction with sustained use. So, it's difficult to answer these sort of overarching questions without just kind of waving my hands and saying, well, it depends on the details of the person's situation and what are some of the factors, what are some of the vulnerabilities that person has, what are the resources that are available in your opinion. So again, one size does not fit all. But one of the things I want to bring out in this, which I think is important, I think that in many ways, I talked about the book and the 265 pages. I would say the heart and soul of the book is chapter 8. And chapter 8 is entitled How to Move from Persuasion to coercion. Because one of the things that I have come to see in the course of my work in all kinds of psychiatric disorders, from substance abuse to the major mental illnesses and so forth, is that the loved ones and families who are struggling with these problems with a loved one generally have not entirely tapped their power as a family, their power as loved ones. Because in fact, at the end of the day, people look to the power of, the doctor's expertise, the power of drugs, or the power of the authorities, the police, to take people, into the emergency room, and judges to involuntarily commit. Those are actually not nearly as robust and efficacious as the power of a family. But so one of the things I find myself doing when working with families is trying to help families find their power, find the power of setting limits, finding the power of deploying the privileges that come from family membership, or withholding those privileges in exchange for people, their loved ones, taking the responsibility to care for their own health. To be able to close some doors and open other doors that can help steer people in a hopefully more healthy and helpful direction. So, and I have no problem in using the word coercion that I talk about why, and remember, I'm a medical ethicist, so I get into the whole ethics of these kinds of coercive measures that families can take, and that families are actually in a better, more both more ethical position and coming from the point of departure of love rather than authority, like the police or doctors or ERs or hospitals or judges, that families coming from loving kindness can use coercive measures to give people things that they want if they do what needs to be done, take things away if they're not doing what needs to be done, from the most pedestrian things like internet access or car keys to some ultimately at the very end of a long line of things, housing, money, and things like that. So I don't have a specific answer to the best way, but I want to call your attention to this idea that for many people, persuasion is not enough. Making the case, pleading with them, talking to them about all these earlier interventions, which I also discuss in my book, about the effect on yourself, on your children, how you're coming from a loving place, your concern about them, and so forth. Sometimes persuasion just isn't enough. And as a psychiatrist, I will tell you that we in psychiatry have some experience with the world of the severity of conditions that for which persuasion is inadequate, and that you have to move to coercion and playing harder ball. So I want to bring out that point in answer to Jesse's question. All right, and then Janet, I think, would be next. Jesse had another one, but we'll go on to Janet, here's the question from Marie. Can you tell me why mini dress is prescribed for nightmares?
Mini press, I think she said. I'm sorry, mini press?
Mini press.
Yeah,
Yeah.
that's a typo.
Yeah, I'm going to have to look up the generic name of mini press because I think that's a very old name. Is it Prozac? I think it's Prozac. Yeah, it's Prozac. Yeah. So Prozac. So nightmares. Nightmares in general have many different causes. Again, here we are back in that theme that I keep returning to, right? Sometimes nightmares are caused by trauma. Sometimes nightmares are side effects of medications. Sometimes nightmares are due to sleep problems that have to do with abnormal sleep architecture and things like sleep apnea. Sometimes nightmares are, actually a sign of certain kinds of illnesses like thyroid condition, even brain tumors. So, but we often have medications that can help people with a symptom regardless of the underlying cause, right? So, for example, cough medicine, right? Cough medicine can help a cough, whether it's due to a smoker's cough, allergy, asthma, bronchitis, pneumonia, right? All these different illnesses that cause the symptom of cough, we have cough medicine for. So all these different conditions that can cause the symptom of nightmares, we have some medications to help with. So one of the medications that we use is called, a category of medications that we use are called alpha-1 blockers. So these are medications that actually affect the autonomic nervous system. Remember, the autonomic nervous system is kind of it has sort of two different parts, the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system and the autonomic nervous system in general are the things that kind of keep functions of your body running beneath the level of conscious control. It's not the voluntary system. So they keep your lungs moving and your heart pumping and your blood vessels dilating or contracting as basis of whatever it is they need to do and so forth. And also have a role in the diurnal rhythms of the brain, the wakefulness cycle, and then the cycling down to sleep and the maintenance of sleep. And there's two parts, the sympathetic, which generally involves, kind of the flight and fight system, getting your heart pumping, getting your blood pressure up, squeezing your adrenal glands to get epinephrine squeezed out into the blood, adrenaline squeezed out into the blood, and the parasympathetic nervous system, which is sort of the housekeeping part of the nervous system. That's the part that makes sure that when you've breathed out, your diaphragm will go down and you'll breathe in. The part that keeps your gastrointestinal tract moving along. The part that innervates your pancreas to make sure your pancreas is, releasing the hormones that it needs to release. So it's kind of the maintenance, the housekeeping section. So alpha-1 blockers work on the sympathetic system. They block certain receptors in the sympathetic system. And those are the area that we think that are responsible for activating the parts of the brain in the brain stem, which is the lower part of the brain that connects the brain to the spinal cord, activates the brain stem to produce the kind of brain activity that goes into nightmares and dreams in general, and nightmares. So there are other actually kinds of medications that one can use for that. The benzodiazepines like clonazepam or lorazepam are used. They work on a different system that's involved with that. So we have seen that alpha-1 blockers can help with nightmares. And it's not, a spectacular help, but it can help and it can take the edge off. Some people obviously as with most things, get a better response than others. Prozac, by the way, has been generic for so many years that I long ago forgot that back when it was first marketed, it was called Mini Press. That's why I didn't recognize it. I don't think brand name Mini Press has been used for at least 25 years. Anyhow, but one thing to be aware of when using this category of medications, the alpha-1 blockers like Prozac, is they have a side effect you got to be careful of, and that is so-called orthostatic hypotension. That means, normally when you get up quickly, your sympathetic nervous system. Make sure when your posture changes and the blood kind of comes down with gravity from the upper regions of the body to the lower regions of the body, it causes the blood vessels to constrict so that it keeps the blood pressure up in the upper part of the body, rather than counteracting gravity, so that the brain especially gets enough blood pressure. So when you block the alpha-1 system like this, it can inhibit the ability of the sympathetic nervous system to do that, so that when you get up quickly, it can cause your blood pressure to drop abnormally and cause you to feel faint or actually faint. So 2 things. One, when you're using these medications, it's very important to learn to get up slowly when you get out of bed in the middle of the night, to go to the bathroom, to sit on the edge of the bed, let your feet dangle so that you can equilibrate the blood pressure before standing up fully, getting up slowly and just resting on the edge of the bed. And when we're prescribing it, we begin on very low doses and bring up the dose gradually until we get, the maximal effect. But you can't start at a high dose, because then you'll really, knock out somebody's blood pressure. And by the way, originally, back when it was first introduced and called mini press, this was actually a blood pressure medication for hypertension, for elevated blood pressure. Okay, so that is the mini press question. Okay, so now just a comment, nice comment here. Your response to the telehealth question is so interesting. The licensing issue is a real insight. That's from Janet. Yes, it really is remarkable. And it looks like, Janet, you dipped into the physician support line. It is amazing. Actually, we've been featured on NBC and Dateline and so forth. The real founders, which I was sort of one of the originals, but I wasn't actually the founder, have been tremendous, have really dedicated a tremendous amount to this. And, we in psychiatry, when the pandemic first happened, we felt, of course, as all physicians did early on, before we all became burned out, not all became burned out, I exaggerate, everybody felt, the noble cause, the inspiration to rise to the calling of the pandemic. Let's roll up our sleeves. This is what we went to medical school for. This is, our moment to, step up in heroic ways, right? So we all had this, we'll take the risks and so forth. Well, the fact of the matter is what was really needed, especially in those early days, were frontline medical physicians who really knew about how to care for severely physically ill people that were in the hospital and on ventilators and had severe pneumonia and infectious disease and so forth. Now, yes, we psychiatrists went to med school, and we can certainly talk about all of those things intelligently. But frankly, the last time that and there are some psychiatrists that continue to work in medical settings, doing consultations in hospitals and the intensive care units. But most of us, like me, the last time that I helped to take care of a patient in an acute medical ward or an intensive care unit was in 1985. Certainly I've had patients who've been in the hospital and been to care units. So we've kind of felt left out. We kind of felt helpless. So what could we do? And we came to see that in a war, you not only need people on the front lines in battle with the weapons and the armaments, but you also need people in the field hospital to take care of the soldiers as they were brought back from the front and to help minister to them, to heal them, to get them back together so they go back out to the front lines. And we came to realize that was going to be the role in the acute stages of the pandemic of psychiatrists to be the field hospital. And that's why we set up this physician support line as kind of the field hospital for the ailing, traumatized, overwhelmed physicians on the front line who did have those skills. And we've continued it ever since. And it was so attractive to psychiatrists who were hoping to contribute that we got eventually 800 people to volunteer. And the idea here is doctors for doctors. And we found, in fact, that doctors on the front line felt much more comfortable and supported by speaking not to a social worker, not to a nurse practitioner, not to a psychologist, but to another physician. So our being physicians as psychiatrists really created a congruence that really, really worked for a lot of these doctors, many of whom, by the way, had never had any mental health treatment in their lives. Many of them were having substance abuse problems for the first time ever, suicidal thoughts for the first time ever. And there's a real issue because many doctors are afraid to go for mental health treatment because they're worried about when they apply for a medical license, are they going to have to reveal the fact that they have a mental health history, and will that cause them to have to get documentation and examinations to say that they're well enough? We're trying to minimize that, by the way, in terms of licensing, physicians licensing. So the fact that this is guaranteed, it's anonymous, okay, you don't have to even tell us your name, right? Come spend an hour with us. And people flooded in, doctors for doctors. So that was how that came about. So it's really quite interesting. All right, next question from Erica. Can you tell me what to expect from Buspar? I will be starting it soon. Okay, Buspar, which again is an old name. Sometimes it's really convenient to use these old names because the generic name, the original brand name, sometimes is simpler than the generic names, which sometimes are really, really complicated. So Buspar maybe is a little bit easier than Buspirone, right? So that's 2 syllables rather than 4. No, 3. So Buspar is actually a medication that has not been used as much as was originally thought and hoped. It's a serotonin medication that actually works a little bit differently from the serotonin reuptake inhibitors. But it was originally developed for the treatment of anxiety. And it is a medication that it turned out that the original promise, because there's always, just like there's always been an effort to try to develop alternatives to opiates for pain, there's long been efforts to try to develop alternatives to benzodiazepines for anxiety. Benzodiazepines, things like Valium, Xanax, Ativan, Klonopin. By the way, all of those are brand names, a lot easier to say than diazepam and oxazepam and all of that. So Buspar was going to be the great hope of, now we've got and by the way, it came out, if I recall correctly, I could be wrong about that, even before the SSRIs, which actually do help with anxiety as well. So it was going to be the great hope. We can get away from these potentially addictive substances that also cause not just chemical dependency, sometimes, not always, but also you develop tolerance to. So we've got Buspirone. Turns out it didn't work that well. Once it was released into the wild in the hands of clinicians, I will tell you that it was kind of a flop. Doesn't mean it's useless. It doesn't mean it shouldn't be out there. It doesn't mean that it's not worth trying, particularly in people who may have contraindications to other things like benzodiazepines, people who have addiction histories, for example. And also it can be used in some other circumstances, such as as an add-on to an antidepressant to get more out of the antidepressant, because that can help. So the nice thing about Buspar, if it works, is it has very few side effects. It was almost too good to be true, right? Non-addictive, very few side effects. Wow, what an opportunity here to have a revolution in the treatment of anxiety. I'm afraid it wasn't so. So it doesn't have a lot of side effects, maybe some headache, some nausea for some people, kind of the usual things. But one important thing to be careful about with Buspar is, first of all, since it is a serotonin medication, using it together with the typical serotonin medications, Prozac, Zoloft, Celexa, Lexapro, Vibrad, Trintellix, and so on and so forth, you can have an increased risk of a very serious reaction. It's rare, but a serious reaction called the Serotonin Syndrome, where you're actually you're over increasing the load of serotonin in the body, and you get fever and delirium and rigidity and sweating, and it's actually a medical emergency that you need to go to the hospital for. I wouldn't be too worried about that, but it's just something to know about. But the other thing to be aware of is that buspirone actually has a lot of interactions with a number of other medications that you have to be careful of. And by interactions, I mean that buspirone can interfere with the metabolism of a number of other medications, including general medical medications, so that by interfering with the metabolism of those medications, it can cause the blood levels of those medications to go way up because they're not being broken down as quickly. They're not being metabolized as quickly. So you can experience toxic levels of certain other medications when you're on Buspar. Similarly, certain other medications can increase the blood levels of Buspar to give you a much higher Buspar level than you were expecting. So, and that's just a simple matter of looking up in the tables to make sure that they're not medication interactions. Now, I will tell you that the science of medication interactions, particularly metabolic interactions, medicines that interfere with each other's metabolism, either speed up the other one's metabolism or slow down the other's metabolism, is a very complex science. It's something that's challenging. We have a lot of computerized databases to help you do this. In my experience, I do not find the level of education and awareness about that issue adequate among many physicians. Obviously, I'm not going to say all, but it's not enough. It's not enough. Many doctors are insufficiently trained and insufficiently attentive, and leave it to the pharmacy computer to create alerts. Because, whenever a pharmacist puts in medication into the computer will check. By the way, one very important reason you should always get all your medications at the same pharmacy. You should not get one medicine here and one medicine there and so forth. Because if you get all of your medications at the same pharmacy, they have your profile. And that means that the computer will be able to run all of your medications against one another and see if there are interactions. But there's a problem with that. The problem with that is maybe for medical legal reasons, the computers often have a great deal of false positives. In other words, they spit out potential interactions that are really either rare, very unlikely, or not of much clinical significance, but there's something in the literature that showed it could be, so the computer was programmed with that. So they give out a lot of false positives, and that ends up creating a lot of confusion. It scares patients. Doctors get calls to say, did you know? And then doctors who may not be that familiar with the science and art of medication interactions might, back out of a medication unnecessarily, or may not entirely understand some of the nuances of the difference between metabolic blockers and metabolic inducers and P450 enzymes and UGP enzymes. And I'm not going to bore you with all of the scientific details, but leaving it to the pharmacy computer to figure out has its own problems. The good news is the pharmacy computer is probably not going to miss an interaction. But I will tell you that pharmacy computers vastly overcall them as well, because they're not clinicians. They're programmed with databases, essentially. So that is an elaboration from the Buspar question, obviously, because Buspar is one of those medications that you have to be thoughtful about, particularly with medication interactions. I think if I recall, it's a 3A4 interaction. It doesn't matter because most of you wouldn't even know what 3A4 means. But the point is there are a lot of medications in that category that can interfere with one another. All right, let's see. Going back, if I missed anything. Telehealth, and last orders, please, if anybody wants to ask any other questions. We're coming into the home stretch here. What, in your opinion, is the best way? Okay. What are your feelings about the medicalization of everything in our lives? Jesse asks. I think it's a great question, and it worries me. If we're going to reduce all thoughts to just the brain, then we're going to end up with no thoughts at all. I think that it's a terrible mistake to get over-invested in the, it's interesting. We live in the time of COVID, and you can see the tension, right, between those who are with the science and those that are skeptical of the science, right? And I want to say there are problems on both sides. There are problems on both sides. I mean, I think I don't have to explain why there's a problem on the side of people who doubt the science and are skeptical of the science and so forth. But the problem with people that are with the science can be a overvaluation of the science and not really understanding what constitutes good science and what's bad science. What are good studies and what are bad studies? And of course, in this time of the pandemic, everybody's rushing to get studies out there. And let me tell you, there's a lot of crap. There's a lot of poorly done studies that are misleading, that are poorly designed, that are incorrectly interpreted, that are flawed in so many ways. Because, and journals, the bar, except for the top journals, the bar for publishing scientific studies for the lower tier journals is really, really low. People say, but it was published, it's science, do your own research, go online and see. Well, a lot of the stuff that you would find in going online, unless you are a scientist or trained, in some kind of rigorous scientific discipline like medicine, you may not know how to read the studies. You may not be able to distinguish junky stuff from really legitimate and reliable studies. So there's also a problem in overvaluing the science, right? So, and in this age, we have so many marvelous and wonderful developments in technology, in the biological sciences and so forth. There's the promise of miracles to come. especially in the domain of biological approaches. And of course, we also have all of these imaging studies and other kinds of testing that you can do that make amazing pictures of the brain and, you know, cause all sorts of things to light up and can look really sexy, you know, when you put them up there and say, wow, you know. And frankly, there are some unscrupulous and sadly famous psychiatrists who capitalize on kind of this overvaluation of neuroscience and claim to be able to put up a PET scan or a beam scan up there and say, look, you see this? This means you've got schizophrenia. This means you have bipolar disorder. No, it doesn't. That is not ready for prime time. Some of these studies that look at, some of the imaging studies on schizophrenia, what they look at is 100 people with schizophrenia, and they find that on the average, more people with schizophrenia have a brain lit up in this area than people who don't have schizophrenia. Does every single person who has schizophrenia have the brain light up more than people without schizophrenia in that area? No, it's a statistical thing. It is not ready to take one person, put one person in the machine and say, aha, you have, you know, a increased activity in your nucleus accumbens in your brain. You have schizophrenia. Wrong, but they'll charge you $5,000 to do that scan for you. And I'm not going to name names, although one particular name is often mentioned in this regard, but I don't want to get into any sort of legal trouble. So, but many of you might know the name that I'm talking about. So the over-medicalization, the neurobabble, you know, you talk about psychobabble, well, there's also neurobabble in my field. And unfortunately, because as we talked about, you know, there are many different perspectives and dimensions when it comes to mental disorders. It's not all just about the broken brain, right? It's also about dimensions and learning and behavior and life experiences and life story. And even those who have the broken brain have important psychological dimensions to what's going on. So the comprehensive approach to particularly mental disorders, really all of medicine, but particularly mental disorders, is to have the 360-degree perspective, to not just throw medicines at people, but also to explore their thoughts and feelings, their mind, their soul, if you will. And frankly, one of the reasons I became a psychiatrist is I felt that of all the specialties of medicine, psychiatry is the most holistic, that is capable of utilizing the totality of what the contemporary states of the art of biology, medicine, psychology, sociology, group psychology, literature and poetry have to offer. You know, I feel like psychiatry is the ultimate intersection between the humanities and the sciences, which is what made me find psychiatry so cool. Now, that being the case, I will tell you that it's challenging because we have increasingly split off and split apart expertise. And one of the most concerning developments in contemporary mental health treatment is splitting the expertise to those people who have deep training in medical biology and all of its associated techniques of, in my field, pharmacology and electroconvulsive therapy and ketamine and psilocybins and ECT and TMS and all of that, right? Splitting those people off, you know, you doctors go do your doctor thing, right? And other mental health professionals who do their talk thing, right? Social workers and psychologists. And then, with all due respect, We have a middle group that doesn't get much exposure to either, gets a little bit, which are the advanced practice nurses. 500 hours of medical training in psychiatry compared to 15,000 hours of psychiatrists, and a little bit of training in psychotherapy compared to 15,000 hours of 10,000 hours of psychotherapy for a psychologist or social worker. But they're thrown in and said, you can do it all. That's a whole different discussion. And I don't mean to offend anyone. There's absolutely a place for advanced practice nurses. In my opinion, I do not support the independent psychiatric practice of advanced practice nurses. I do support the collaborative psychiatric practice in conjunction with physicians and psychologists of psychiatric nurse practitioners. I'll probably get into trouble for saying this, and I'm prepared to debate anybody about it and to support that. But the point is, and I digress here a little bit, but the point is that the fractionation, the fragmentation into the medical folk and the psychological folk and maybe the psychosocial folk, you know, the folk who just will deal with your family. I don't deal with the family. Go down the hall to deal with the family. You know, I don't deal with, you know, the problems that are going on in your marriage, but let me ask you, you know, how's your energy? How's your appetite? Are you moving your bowels okay? If you had any seizures from my medication, how's your blood pressure? Okay, I'll up the medication. You want to talk about what's bothering you at work? You want to talk about what's going on in your marriage? See the social worker down the hall. See the psychologist down the hall. I don't think that that's, I mean, I understand why it's happened. And I understand some of the financial things that have driven that. I understand some of the manpower, person power things that have driven that. I understand that. Access to care things that have driven that. I understand that. But I think there's a lot of degradation in the quality of care that fractionation does, and the lack of teamwork that often, listen, let me tell you something. I have some, so I don't practice that way. I'm a one-stop shopping guy, okay? You come to see me, you're gonna get the whole thing. We're gonna talk, we're gonna spend an hour together, either a half an hour together, an hour together, sometimes 90 minutes together. The smallest part of our sessions is gonna be asking you about your meds, but we will be, and we'll be making med adjustments, and we'll be dealing with side effects. Yes, we'll do that. But that's not all we're gonna do. We're going to do comprehensive 360-degree mental health care. Now, I do have some patients who go to therapists also, very few, but I do. I try to limit it to therapists that I work with, that I collaborate with. Some people come to me from therapists that I don't have experience with. And I will tell you, it's unfortunate, but a lot of the times, the attempt of me to try to connect with them and talk with them about the case, phone calls go unanswered, finding out, you know, what's happening from their end with their sending me their notes or calling me so that we can both be on the same wavelengths that are not leading people in two different directions. It doesn't happen always the way that it really should, and so forth. So the medicalization of my field has pushed psychiatrists because of perhaps the skills that other people don't share with us into a fractionated corner. And then for other people who may say, well, look, we don't want to just do talk therapy. We want to be able to give medications too. There are now certain states that allow psychologists to take a 100-hour course and they can prescribe psychiatric medications, 100 hours, right? If you add up medical school plus residency, we're talking 15 to 20,000 hours, right? 100 hours, diagnose, make sure, you know, you can figure out, do they have a brain tumor? Do they have an endocrine problem? Yes, no. What are the side effects? All these medication interaction things that I've spoken about, 100 hours. And you can be a prescribing psychologist. So these are the kinds of, I understand that I've taken the liberty at the end here to go on some of my favorite rants, but those of you who have known me from past years, the last 8 years, know that as I get more and more fatigued, as we get to the hour-and-a-half mark, I start to let go of my rectitude and start to get into some of my more rantable topics. And I'm concerned about that. There is a place for every mental health professional. We need them. We need everybody, but we need coherence. We need completeness. We need depth as well as breadth. And that is what our, especially mental health care system, is increasingly lacking. And that is my riff on my feelings of medicalization about everything in our lives. Jesse. All right.
Thank you very much.
I'm not sure anything else came in. Just some thank yous and thank yous, which leads me to say thank you for your attention. Thank you for, I see there are 11 people all the way to the end for hanging in there with me. I apologize in advance for any way that my strong opinions on certain topics might have inadvertently offended anyone, but I hope at the very least I've taught you as much as I can possibly pack in to 90 minutes, and I look forward to our ongoing harvest in years to come.
Thank you so much, Dr. Komrad. And I'm glad you said that because I was going to say we want you back. So thank you so much.
Maddie knows, we're married for life.
Okay, there you go.
Yes.
Thank you so much.
Thank you very much. We really appreciate it.
You're welcome. Thank you all so much. Take care.
Take care.
Stay well. Doctor's orders.
Okay, thank you. You too.